Thank you, everybody, for continuing the discussion this morning as we talk about diversity and patient engagement. I think we've had some of these issues come up in some of our discussions earlier today and yesterday, and that when we think about diversity and engagement, this really can be a very broad sort of sense in terms of engaging different people with many different types of perspectives. So I'm really looking forward to hearing our speakers today as they talk about the work that they've been doing. And this is really one of the main themes, I think, that came out of the reviews, the interviews that you did as being something that's important for us. So I think everybody is going to introduce themselves just a little bit, is that right? And look forward to the discussion. Thank you.
So we're going to start with the video. Daniel, do you want to give any context, or do you want me to just hit play? Hit play.
So I got a call from Carolyn yesterday, and she told me that she just found out that she's HIV positive. But I'm concerned about her because she says she's not willing to go to the doctors because she heard about all these drugs that you have to take and how they make you sick now and you're in the bathroom all the time and you can't ever leave your house. Now, I know that you are HIV positive. Do you have any advice that I could pass along to her?
Well, I would be free to talk to her anytime you wanted to.
Right.
But what you can tell her is today is a whole new era as far as
really?
HIV medications. I'm on one pill a day, once a day.
Wow.
And with that one pill, I have no side effects whatsoever. So it's just like you get up in the morning and you take a vitamin. You know, but that being on that one pill has helped me be undetectable.
So does that mean that everyone can just take one pill now?
Well, no. If once they get into care and their doctor do a test to find out what strand of HIV they have, then they will find the best medication for them, for that particular person. But the good news is, almost for any strand, there is a possibility that you can only take one pill. So I would highly recommend that she, get in care. It's not as bad as what she thinks. Once you have that primary care doctor, then he can actually work with you not only with your HIV medication, but with your general health as well. So, no matter what comes up, it's not like she has to go any specific place, but she can find someone who will treat her and help her with finding the right medication for her.
We're going to go through you.
Hi, my name is Gail Graham. I'm community partner with Dr. Mullins' Patients Program. I met, I was a volunteer at my church, Mount Lebanon Baptist Church, and Dr. Mullins and his team was there visiting with my pastor. And my pastor came to me and he said, Gail, I'd like for you to sit in on this meeting, this meeting with some researchers. So the first thing I thought was, okay, he can give me something else to do. And then the other thing I thought about was the research part. We had developed a great relationship with our community. And we previously had some people come in and they did research, got all the information they wanted, and never came back, didn't give us any feedback. They were insensitive to the community as a whole. And so that actually damaged the relationship we had. So we had to work on rebuilding that relationship again. So when I heard research, I was like, nope, I don't think I'm going to do that again. So I go into the meeting, and Dr. Daniel goes through his whole spiel about, the patients program and blah, blah, blah. And I'm sitting there with. So then he said, well, would you be interested? No. And so he looks at me and he goes, so he rephrases it, and I'm still sitting there. No. So maybe around the fourth time, he said, he asked me again, and I'm looking at him, no, I'm not interested. I have a lot on my plate, no, I'm not going to do this. So then he says, well, would you mind if one of our team members just give you a call later on down the road, maybe, you know, have lunch and you can discuss it. So at that time, I just wanted to get out the meeting. So I'm like, yeah, okay, sure. So when the young lady, Yawande, came and, you know, we sat down and she went through her whole spiel to it, and she got the same exact reaction that I gave Dr. Mullins. No, I'm busy. I only did this because, you know, I was trying to get out the meeting. There's nothing you can say, I'm not interested. So then she said, well, we're aware that you do a testing for turkey event, and we do that for World AIDS Day. So anybody that comes to get tested will get a free turkey. And it worked out pretty well. So, and we used that time to do HIV awareness. We educate them. We do preventative. We give out condoms and everything. And we do some counseling during that time. So she asked if they could have a table at our event. So I'm thinking, I'll give them a table, sit them in a corner, and, you know, somewhere where I can watch them and make sure that, you know. So I said, okay. So the actual day of the event, they were the first team to come. So they helped us set up. And as the community was coming in, Ebenezer, one of the team members, said, would you mind if I go to Dunkin' Donuts and get some donuts and coffee for the community? And I'm like, no, that's actually very nice, thank you. So he went and did that, and we had like over 100 people. So they came back and they set it up, but they went to the tables and was just, you know, talking to people, bringing them donuts and coffee. And then I noticed that Yawanda was talking to someone, and she was like this, and, you know, just paying attention and just talking to them. And at the end, when people were starting to leave, the volunteers were leaving, and we still needed help with the testing, they jumped right in. So by the end of it, I was like, okay, you got me. Whatever you need, I'm there for. And so that's how I became a part of just a community person with Patients Program.
We're going to go through a couple of points in a minute, but just a brief introduction. I was kind of the worst number crunching nerd you could imagine. Before I went to graduate school, I worked in an actuarial department. If you don't know what that is, those are the people who set your rates. And then I joined University of Maryland, where I became the person who was known as like the guy who can write AIM 3, which was your cost effectiveness aim, right? So you guys go and do things, and then I will evaluate the data and tell everybody that it works, but we can't afford it. But I was blessed that many of the people who asked me to be, you know, in charge of AIM 3 were doing work in the community and really making an impact. And one of the things that I had the opportunity to do was to go into those community environments, the clinics, and to talk to data points, which if you're a number crunching nerd, you never get to talk to a data point before. And it really changed the way that I thought about analyzing data. And years later, when this whole concept that, you know, evolved through AHRQ and PCORI came into existence, I really got it because I had had that opportunity to talk to data points and say, you know, like, why are you an outlier? Or, you know, like, why does this not make sense? And so that's been my journey. And we're going to share 4 points with you.
The first point would be to get to know the community and their needs first. And the way that you can do this is you will locate support groups in the community and just visit and see, you know, what was going on there. You can do it with churches. You can also Google, you know, the CDC, and you go by the zip codes to find out, you know, which part of Baltimore or Maryland has the highest rate of HIV. And so then you would go from there. And then when you connect with the support groups or the churches, like for instance, my church, we had already developed our relationship with the community. We knew that besides HIV being a high rate, we had a high re-entry rate from people coming back from prisons. And we also had a high rate of Narcotics Anonymous and NA people. So we then would work to try to get services, set up like health fairs where we'll have somebody there to help with expungement and different things. So when you partner with the group, you're opening yourself up to a lot of information that is valuable at that time. And then you're going with, they develop that trust in the community, so the community is going to give you a little leeway and trust. So once you develop that, you'll get valuable information from them, but you also give back to them. And that for the research or whatever you're doing, after you get your information, come back and give them an update on what's going on. And that will go a long way. And also, the researchers might come for one thing, but because of the relationship you establish, and when you find out that they're looking for something else, then you can refer them to maybe another church or another support group that you know of. And so you're just building on that relationship. So it's very important that you get to know the community and their needs.
Our second point is listen from the community lens, not your own viewpoint. A little bit more about the patients program at the University of Maryland School of Pharmacy. We are funded by a 5-year R24 grant, which is an infrastructure building grant. So we actually are an infrastructure to help researchers and communities co-develop research together. We have a representative from each of the 7 professional schools. So we have a representative from School of Medicine, School of Pharmacy, School of Nursing, School of Law, Dentistry, Social Work, and Public Health. And then we have an equal number, actually one additional number of partners from outside University of Maryland. And that's strategically set up so that for shared decision making, if the University of Maryland doesn't do well by our partners, they can outvote us. Together we decide what we're going to study, but we also together train people in what is this thing called patient-centered outcomes research. And so the University of Maryland's patients program has a vision that's rather simple, and that is that patients and stakeholders are heard, inspired, and empowered to co-develop patient-centered outcomes research. Patients and stakeholders are heard, inspired, and empowered to co-develop patient-centered outcomes research. Our community is West Baltimore. If you're not familiar with Baltimore or West Baltimore starts at our campus and goes north to North Avenue. Some of you know North Avenue because you were addicts about watching The Wire. And if you remember the drug trade, that was North Avenue. The other thing that you may know North Avenue about is the civil unrest last year, when what you saw about our community was a CVS that was burning on North Avenue. That's the northern boundary. To the west is Mount Lebanon Baptist Church, and if you go 1 block over, you get to Mondawmin Mall. You may remember Mondawmin Mall from last April as well. And what you saw about my community was looting. But I know the rich history of that community. I know that that community developed the careers of people such as Billie Holiday, careers of people such as Cab Calloway, careers of people such as Supreme Court Justice Thurgood Marshall. And that's the community that we serve. When patients and stakeholders feel heard, when they feel that you are listening, when they feel valued and respected, they will be inspired to find the time to serve on advisory boards. In contrast, when patients feel that researchers are just trying to check the box or fulfill a quota, they feel angry, disrespected, and disempowered. And that is why we had the civil unrest that we did in our city last year. There is no feeling more horrible than the feeling you get when you don't believe that you are being heard. There is no feeling more horrible than the feeling you get when you don't feel that you are being heard. So how do we transform the research enterprise so that research is conducted from the lens of the community in a patient-centered way? How do we transform research so that research is not about treating patients like guinea pigs, but rather about finding solutions to problems that real-life patients care about? Well, we heard some of this yesterday. It's about pre-engagement, which is getting to know a community first, even before there is a research project. By committing that we will be there, after all, isn't that what getting engaged is all about? Getting engaged is a promise, a commitment to being with someone in good times and in bad, in sickness and in health. Now imagine being engaged with a community in the same way that you want the community to care about your research. Imagine mourning the death of Freddie Gray and the dozens of other young black men who are killed each year in West Baltimore, rather than being afraid of going outside because you see a CVS burning. In our first contract with PCORI, we were trying to learn from the community how they felt was the best way to engage what they call hard-to-reach patients, similar to what Dr. LaValle herself and her colleagues found in her INSPIRE project. We heard a lot about trust and respect. And we weren't surprised to hear about trust and respect. After all, anyone who has done research in the community knows that trust and respect are key. One of our community members really taught our researchers a lesson. Most researchers think that homeless people have nothing to do all day. And so it should be easy to get homeless people to answer a few questions. What researchers don't realize is that if a homeless person meets with you to answer your questions, that's time off in the corner where they could be earning money. Listen from the community lens, not your own viewpoint.
Also, diversity. It isn't just about color. It's about the experiences, different experiences and different ideas. So you would want to get a group together of not only just an example of heterosexual males and females, but you would also want to get gender neutral, someone who doesn't identify with either sex, transgendered people, gay, lesbian, bisexual. That way you have a voice from everybody about certain issues. Depression. Maybe you would want to speak to a teenager who's been experiencing bullying. They go through a form of depression. You also have postpartum depression from moms. And you have, when you have chronic illness, you go through a form of depression. So again, it's not looking at just one specific group, but just getting ideas from a range of areas.
And our last point is seek honest answers, not just diverse responses. Diversity has become a checklist, and many funding agencies are requiring that researchers engage diverse patients. I support that principle, but the ultimate goal is about helping patients to have relevant information that applies to patients like me. Diversity is not just the severity of my disease, my gender, my race, and my age. Diversity is about what is important to me. It's about my preferences for the types of treatments that I want. It's about what I hope to achieve out of the healthcare I receive. And it's about what I want to avoid. And it's about respecting my decision, even if my decision is not to receive healthcare. In patient-centered outcomes research, we should strive to achieve diversity in responses to important healthcare questions, not just diversity in those who provide those responses. In patient-centered outcomes research, it is important that we seek to achieve diversity in responses to important healthcare questions, not just diversity in those who respond to our questions. In many of the neighborhoods where we work, a $25 gift card is enough to get you a response. You can get someone to fill out a survey. But getting someone to fill out a survey doesn't mean that the person told you what they think. Some patients will tell you what they think you want to hear. In research jargon, that's called social desirability bias. So here's a question. Why would a patient do that? Why would a patient not tell you the truth, but tell you what they think you want to hear? The answer is the researcher wants to get 200 patients to fill out a survey, and a patient wants to get a gift card. Now, I'm not saying that everyone is this way, but there are some people, certainly not many, certainly not all, there are some patients who may feel that if they tell you what they think you want to hear, that maybe you'll ask them to participate again in a future study. And then they'll get another gift card. So I am 100% committed to the concept of compensating patients and other stakeholders for the time. Since we all get paid, they should be compensated as well. In fact, under most circumstances, I insist on offering patients compensation for their time. But I've come to realize that it is more important to respect patients and their time than to merely compensate them. So one comment that I have heard often from the community when we do go out and do surveys is, why do you, this is the community speaking, why do you, meaning you researchers, why do you keep asking us the same questions? Don't you ever talk to each other? What this says to me is that many patients in the community feel that we are not respecting their time. In fact, we are wasting their time by asking the same questions over and over and over again. And what is the result? In some cases, people will give us the same answers, even when the question changes. So we must ask ourselves, are we seeking honest answers or just diverse responses? That would turn it over to you.
That's great. How do you follow after that? Wow, thank you for setting up such a high standards. But my name is Linda Ko. I am a researcher at the Hutchinson Cancer Research Center, and I also teach at the University of Washington Department of Health Services. A little personal background about me is I was born in South Korea, but I was raised in South America. So I learned to write, speak, and write, speak, and what's the other thing? and in Spanish before I did in any other language. So Spanish is my native language. And then it was important for my parents that I knew how to speak Korean. So they got me a tutor, and I was able to keep up with the Korean language as well. And then they always wanted to come to the United States, the country of dream, where the dreams come true. And it took them 12 years to get their legal visa to be able to move to the United States, to immigrate as a legal resident. So that has been always a very important part of me. So the kind of research that I do, the population that I work with, has been with immigrant and minority populations. And my training and in the doctoral program was about using community-based participatory research to engage the community. So based on my training and some of the work which was in North Carolina and the prior work that I've done in North Carolina, that's always what I wanted to do. I wanted to start with the community rather than starting out with the science. So here are the questions. So I moved to Seattle about 5 years ago, and I started talking to different communities and thinking about what are some of the things that we can do. Now these are the questions that I get from people when they know that I've been working with the community, and they will ask me this type of questions. So I thought maybe these are questions that people will be curious about in this session. So these are the questions that I came up with. So the first question is, how do you start a community advisory board? I always operate with a community advisory board that represents a diverse group of community members. And the answer is, it really depends. There is really no one straight bullet that can help you achieve a diverse group of community advisory board group. And I can give you an example, and this is why. I wanted to work with the Hispanic community after I moved to Seattle. And I was starting to engage the community in Seattle to do research that they wanted to do. But then there was another senior researcher in my center who has been working at Eastern Washington, the Yakima Valley, for the past 30 years. And she was thinking about planning for retirement. So she said, Linda, do you want to come and join our CAP? So I said, oh, sure, that would be great. Who does that, right? So I went and I sat in her CAP and I listened to the community for quite a bit. And then one of the projects we're finishing up. And so she opened the door and she said to the community, okay, guys, so this is finishing up. What's next? What is the concern? What is the next concern that we should tackle? And they all said childhood obesity. At that point, she was planning retirement, so she said, Linda, do you want to work with the community on this issue? So we said, okay, folks, we're going to go back and see what kind of program announcements or applications that we can apply to from whatever funding agencies. And we actually, it's very, very close to that time, we had a RFA come out for the R24. Now I'm realizing that Daniel and I were probably in the same grantee group. So, you know, same people, similar people think alike. So we saw that announcement, and then we went back to the community, to our advisory board, and we asked them, do you want to do this? This is going to be a capacity grant. This is going to give you a little bit of time to work with me, to get to know me. We will build infrastructure. We'll be able to do a more comprehensive type of needs assessment about childhood obesity. We'll be able to create pilot study interventions together. So do you want to do this? And they said they wanted to do it. We got tremendous letters of support from them. We got city mayors, school principals, district, school district representatives. I think we got like 35 letters of support or something like this. And then, so we submitted, and then luckily, which is really hard to get funded this stage, but we got funded. And then as we were joining the existing CAP, they also had other projects that they were working on, and it was becoming a little bit difficult to have a 1-hour community advisory board meeting where we talk about so many projects. So at that point, the senior researcher said, Linda, do you want to become your own independent CAP? So I said, okay, you know, and so we became our own independent CAP, and our CAP is called Together with Stripe. So that's how the CAP in the Yakima Valley was formed. I also, so if I remember, I told you that I've been working with the Seattle folks as well. So it's at the same time I was meeting with different people and trying to build another CAP here in Seattle, which took a completely different round. It was just meeting with different people, having coffee, lunch, you know, just, so it was a lot of time out in the field, different folks who were interested in working with researchers and addressing community issues. And finally, when I got 5 people who were interested, we got together at the Fred Hutchinson, and it was most of the people were representative from Asian subgroups. So we got together and we said, what are the concerns of your community? And they said cancer. And they wanted to do, they said, first priority was stomach cancer. They already had their priorities down for me. So stomach cancer, colorectal cancer, breast and cervical cancer, they had their list of priorities. So when we went back and then we did some science, stomach cancer was going to be a little bit difficult to get funded because there was no clear guidelines, and insurance coverage was going to be a little bit difficult based on the clinical guidelines. So we said, well, colorectal cancer, there's a very clear guideline. People need to be screened. It's paid, so why don't we go with the low-hanging fruit before we go with something that's going to be a little bit more difficult to get funded? And they said they were all excited about it. They wanted to get on board, so we started working on that topic. At the same time, PCORI put their first pipeline award, and one of my community partners, I just opened it up to the group and I said, well, this could be an opportunity for us to tackle stomach cancer. Who wants to lead this? And then one of our community partners, Suzanne Pack, said, I want to lead it. So we wrote the pipeline award together. She's the lead. All the funds are going to her organization to put activities together. And she got funded. So we're going with pipeline 1 and the pipeline 2 and the pipeline 3. And so a lot of ideas are coming from our CAP, and another idea that came out from our CAP was from I try to put their name here so I don't forget about it. They go by NAPCA. It's National Asian Pacific Coalition for Aging. They were getting interested about heart disease among Asian subgroups. And I just didn't have the time to be able to tackle that topic at that time with so many other things that was going on with different projects. We already have 5 funded projects. So that's already pretty much maxed out on my time. So I said, if you want to take the lead, I will help you write it. And they wrote a program grant to Walmart Foundation. And she recently sent me their award letter that they got funded. So a lot of things are happening, not only in terms of research that it's real scientific advancement, but also program-related grants that they're writing to build their infrastructure. So we have the research arm and the program arm moving together. So those are some of the examples. So what do you do with the CAP? So people would come and they would say, what do you do with them? And so the CAP, for the Eastern Washington CAP, we meet more often. The CAP meets quarterly, 4 times a year. All the CAPs meet 4 times a year. I'm sorry, I'm going back and forth. Or all my CAPs meet 4 times a year. The Eastern Washington CAP, because we have an active, so we got the phase 2, the UO1, Daniel? Yeah. So we got the phase 2, so we got the phase 1, the infrastructure building grant, and then NIH put out the phase 2, and we got the phase 2. So it's very active, it's very busy. So, and we couldn't make, everything that we do, we go to the CAP, and we say, what do you guys think? What do you think about this? Are we in the right direction? So it was hard for us to go quarterly when we needed to make decisions right away. So we asked them, can you please, some of you guys who have a little bit more time, who have more vested interest, volunteer a little bit more. So they themselves volunteer to be part of a steering committee, and the steering committee means bi-monthly. And we go, we meet up with this steering committee to help us make decisions on things that needs more urgency. And then we go with the larger CAP quarterly to give a report and then to help us shape some of the decisions that came out from the steering committee. And I also treat them as my co-investigators. To me, they are another scientific arm. They are, I call them my community co-investigators. I tell you guys are my community co-investigators because you tell me the expertise that I need to understand your community. And they have a say in every aspect of the science from beginning. What do you want to be working on? What do you think is the next grant that we should write together? So from that end, all the way to how we should disseminate research. So I know for researchers, there was a discussion in the table. It's very easy for us to just think about publication. But they would say, can we go to this newspaper? Can we go to that newspaper? And the newspapers always want the researcher face there, and and I try to bring the other face of the community. Sometimes I'm not there in the picture at all, so that they can see that it's the community who is taking charge of the project. How do you build capacity of the CAP to engage research? And I underline capacity because capacity can mean many different things for many people. But when I think about capacity, I think about helping the community work with me in research and also through the process, oh my God, helping them empower so that this project is not just a research project, but it's become something that the community takes ownership with. So something that we do in our CAP meeting would take about 15 to 20 minutes to do a little discussion about research. We throw out a lot of researchy terms, IRB, CBPR, randomized controlled trial. We throw a lot of words, thinking that this is an idea that people will be able to pick it up. But we talk about this. We said, let's just talk about something that's called human subject protection, that we researchers call it Institutional Review Board, IRB. And then we talk about the Tuskegee trial. We talk about some of the more unethical trials that we are very aware of. And then we talk about what do we want to do as a group? How do we want to do research? We want to protect patient confidentiality. We want to be very mindful about people's rights. And that really engages the people and for them to be able to say, this is how I would like our CAP to work together. Activities that I feel that it empowers the community is when you really give them the power to make the decision. So for our pilot intervention project, it was the intervention project that I packaged it. So what we did is it had to be an evidence-based project because it has to be a scientific project. So we made a list of evidence-based projects that we thought is something that every scientist would feel comfortable with. So we reviewed websites like Community Guide or Research Tested Intervention, COCOMO Strategies. These are all websites that upload intervention materials that have been tested based on science. So we made a list of those, and then we went to our steering committee and we said, folks, these are the boundaries. We need to do multi-level. It has to be several levels. It has to be evidence-based, and these are all evidence-based. It needs to be something that we can accomplish in a year. Can you help us package it? Can you come up with 4 different packages of interventions? So they packaged it, intervention, pilot intervention A, B, C, D. And then we took those, and then we took it to our community advisory board, thinking that they were going to pick either A, B, C, D, but they said, no. We want to repackage this. So they repackaged that into 2 interventions, which we called it again A and B. And then we took it to the town hall meeting. We had a town hall meeting, and we said, can you guys vote which one you want, A or B? And they said, no, we want to package this. So it ended up going through this process of repackaging and repackaging, having this dialogue. And it ended up becoming the intervention that they wanted it. And they took such an ownership with it. So one of the activities of the intervention that they wanted is something that's called Ciclovia, which is an activity that started out in Bogota, Colombia, which is an open street event. So you close out, you've probably seen it, but we probably used different words for it. You close out streets, and then kids can bring their bikes, or people can bring their, they can have a Zumba activity in one side, and they can have cooking demonstration on the other side. So they wanted something like this. And then I said, I freaked out, because then I need some kind of street permit, and I don't know who to go to. So, okay, guys, how do we get the street permit? They got it. They got the street permit. They made sure that we had everything ready. They contacted their folks. They had a police officer to provide security. So it's that kind of empowerment that I see, that when they put so much input in it, they feel that this is theirs. So now with the second phase of the project, something that they wanted to see more happening is to going to schools and making sure that things are embedded into the school system so that it's more sustainable. So I'm going back tomorrow to talk to the school superintendents and the principals, and just to listen to them and see how they see some of these activities that the CAP wants to see it happen could be integrated into the school system.
So I think those were 2 great discussions, and I'm so excited that you were both here to talk about your respective experiences. And I will say the one thing that resonated with me, and then I'd love to open it up for discussion, is, I think I think what researchers fear is when you open yourself up to a community, you have to then open yourself up to these different needs that we don't have a toolbox to address, right? Getting a street permit, I would be lost. Dealing with issues around homelessness or access or other things that aren't part of what I know how to do as a researcher is freaky, right? But when you start to look at your patients or your community members as partners, then they can help you solve those challenges. And I think it's making us step away from we are the principal investigator, right, to we're part of a team that's working on this project together. So that really resonated with me, and I appreciate you both taking that from different angles. So first of all, applause to, and I've got a glass of water, but applause for great presentations. So I want to open it up for questions. We're gonna talk for about 20-ish minutes, and then we're gonna go back and do table discussions, similar to what we did before, tackling a question of how do we move this aspect of research forward. Does anybody have a question? Yeah, perfect. Kim.
Secret microphone. Hello. The work that you're all doing is amazing because you're starting from the beginning, right? So you're involving people right from the beginning on doing research. Now, I'm not a researcher. I don't know how researchers otherwise come up with ideas. But what happens, this seems to me to be the question I can't find an answer to. What happens to, a researcher comes up with a project, we're going to study this. how do you then, after the fact, if the community's not involved, how do you go about getting them involved later on?
I can start, because we have a formal process for that. Is we take a researcher into essentially a focus group, and we have the community do a thumbs up or a thumbs down. And if it's thumbs up, then we continue the conversation. If it's thumbs down, then we consider reframing it so that it might be thumbs up. We remind all of our partners that everything is voluntary. I mean, even the discussions about research. So if it's not something that the community is interested in, then we just perhaps go to another community partner, or perhaps save somebody 6 months of time so they don't write a grant that's not going to get funded. But then comes all the rest of the steps, which is, if you say thumbs up, why? Like, why is this important? And I explained to the researchers, you might want to take some notes because they're writing your significance section for you, right? Right. And then we talk about, like, well, who should be involved? Now, that's your inclusion-exclusion criteria in case you're not paying attention, right? And so when people say, well, how can a patient help you to write your research proposal? I'm like, come into our meetings, and I was explaining this last night, is you only get to talk when we call on you. And really have the researchers listen. And the community really will write much of the grant for you.
I agree completely with Daniel, and the strategies that Daniel is using to involve researchers who have been already funded or who already has an idea. I think some researchers do need more training in more patient engagement. So we do have a very similar approach where the community will vote whether this is a go or if it's a no. And if it's a go, then I work with the researcher to train them how to work with the community. I was dating in the past where I thought, I knew this person, so I thought this person would be able to work really well, and then it just did not end up being a good match with one of my community partners that I matched them. And then my community partners called me and said, Linda, do you know this? So you hear this and you hear that. So I said, okay, I want to just avoid all of that. So we established something very similar where they have to vote first. And then after that, I work with the researchers to bring them up to date of, what are some of the things that really work? Just like we're discussing here, if they wanted to work with the community, what are some things that X, Y, and Z, they need to have it under their belt so that, the relationship is sustainable and they can keep going. I'm sure that's what the researcher also wants. They don't want just one thing, right? They want things to be sustained.
Mashid.
What was the biggest problem that you met in this whole process?
The relationship of the researchers with the community. I think that there should be a one-on-one class for the researchers on how to engage the community, how to have the empathy for the community, how to speak to the community. If you have that sensitivity training, that goes a long way with engaging the community itself. So.
I think about this term pre-engagement that we use, and I think early on I thought that pre-engagement was kind of getting to know the other institution. But we've really evolved in our thinking that pre-engagement occurs every time you start having a new conversation, right? And again, research is always voluntary. So not everybody is as challenging to get to work with us as Gail was. But we always go through the pastor, or if the pastor passes us on to somebody else, we go through that. But to remind ourselves that even if they've done 5 studies with us, that there's still that pre-engagement of, is this an important topic to you? And even at the level of, is this still an important topic to you, right? So, we had a conversation last year, and so we do an annual update with the pastor to see what are their current priorities for that church that he would be interested in. And over time, we really have evolved to really asking about those things. And I think, the Testing for Turkeys event was really the turning point for us, at which point we begin to realize that that's really what it means. And so we have, more failures than successes like every other, partnership. But we don't just go after PCORI funding, we go after things like trying to get their kitchen back up to professional grade so that they can implement the kind of chef training program that used to exist before they lost their funding. And so it's one of the things that we're currently working on. And what's fortunate for me is that my dean and the campus president understand that we're doing those things, and they don't ask, well, what does it have to do with health? If you don't understand what having a community kitchen that provides job training for future chefs in West Baltimore has to do with the health of our community, I'm glad that I have a dean and a president who I don't need to explain that to. So, yeah.
I think for me, in the beginning, it was engaging a community that had a bad experience with another. I don't want to say with another researcher, but in terms of research. So I went, and when I had coffee times with different people, they said, I remember giving a letter of support to someone at the university, and then they're gone. And then they came back again. They wanted another letter, and then they're gone. So at that point, I realized, wow, I think someone mentioned this, that updating is very important. It's like, oh, even if you get funded or not funded. And then from the researcher perspective, I'm sure it was very difficult for the researcher when they don't get funded to be able to say, sorry, folks, we didn't get funded, but we're resubmitting the grant, so can you give us some, like I could see both ways. I could see from the community perspective, but also from the researcher perspective. And I think you mentioned that, but so that was an eye-opening moment for me. Oh, I have to be able to think about from the community perspective that they want to be followed through. And the second thing that kind of follows along with that is the funding. And we write grants, and then we won't hear about it until a year later, and especially with the National Institutes of Health. So, but it's as much as we try to explain them and that's if you're lucky, right? You get funded in a year, but you may have to go to a couple of resubmissions. But it's to get them energized and engaged. So we try to have different activities. I'm really glad that my community partners have their own activities on the side that we can all assist. So we provide updates on those. But for me, those two things have been the most challenging.
What other questions are there from the group? Karen?
Could you talk a little bit about compensation, actually financial compensation for your community partners, and sort of how you do that before you have funding and then while you do have funding?
So for the R24 mechanism that Daniel and I were funded, we needed to bring a community person as a community investigator. So whoever that person is brought up as part of the budget. Historically, what has happened with the Community Advisory Board in Eastern Washington is they are there because they want to be there. So they get lunch, free lunch, a lot of feedback. Just like Daniel said, sometimes it's not the competition, but it's feeling heard and feeling that people care about the community. So we haven't been compensating our Community Advisory Board. We did do one survey when we wanted to understand whether we're working well together. So we asked them to fill out a survey. Please tell us, what can we do better? What are some of the things that you think that we can do in order to maintain our relationship stronger? And then they got a gift card for a small amount for that, but we haven't done compensation for the CAP.
So I'm going to differentiate the kind of the funded from the unfunded. So in general, we fund. Anytime we do a focus group, even if we don't have funding yet, we always provide gift cards and food and water and stuff like that. And when I'm not being filmed, I can tell you some clever things we've learned about ways in which you actually can get food at a place, even though the government doesn't allow you to pay for food. But I don't want to say that on camera. That's right. So, our gift cards range from $25 to $50 if it's just asking for advice, and then if it's kind of more intense, it could be higher. When we're paying advisors, they get $500 a day. We tell researchers that we won't support their program if they don't fund at least the NIH reimbursement for study section. But we've never had a researcher to date who dropped down to like that $320 per day level. everybody's agreed to pay at $500, and everybody gets $500, whether you're, head of neurosurgery or whether you're a patient. So those are common things, I think. In terms of developing proposals, aside from if we bring in a focus group, if we're working with a person who we intend will eventually be one of our community advisory board members, part of training them in research is saying, we all put in our time for free at this phase. If it gets funded, you'll get that, but you don't get that when we're developing the proposal. And I think that is important for them to understand how all that works, because they begin to appreciate at a deeper level just how challenging it is. Because if you think a good hit rate these days is, 15%? So we tell them that means at least 6 proposals before one gets funded. We do tend to recycle people towards the end of a current. So the way that the patients program works, we have these partners, and we always work with the same partners if possible. And we always know what the portal is. So in Mount Lebanon Baptist Church's case, it's the pastor of the church, and he will identify someone. One of the examples we had for a PCORI clinical trial is, the reality of a cancer trial is that patients with cancer sometimes die. And so at the beginning of that trial, one of our advocates died, and I had to call the pastor and say, we're going down to National Cancer Institute next week. I need, essentially a Black female survivor who underwent radiation and is willing to speak boldly. And he knew who to choose. And so that's why I have a different feeling than some other people, because we have done training with her since then, but when you have portals to the community and you explain what you need, and I needed a person, and you know who this is, who could go down to NCI and look at a physicist, because we're talking about the way in which a radiation beam, does or does not, follow the laws of physics, but they've got to be able to sit through that. And there was no way I could train them to understand that. I didn't even understand that session. But I knew that the pastor would send me somebody, and there were a couple points during that meeting when people, both from PCORI and NCI, pulled out their pens, and it was more often when we had our patients speaking. We also won't support researchers who won't have at least 4 patients or caregivers, and so we just have certain rules, and if they won't do it, we won't support them. And what I find is that by establishing rules, you really force people to advance the way in which they do PCOR. And if they don't have funding for those focus groups, the thing that we're fortunate is that we had built that into our R24. So at least for 2 years and a couple months more, if you come to me with a good idea and we need to do focus groups, I have funding in my R24 to support that. And then one of the things that our dean did was she also gave me supplemental funding, because she understood that this was an investment in our campus. And she knows that, if I need to buy T-shirts or I need to buy water bottles, that it's really hard to convince funding agencies why you need T-shirts, but you need T-shirts.
So, Daniel, you mentioned not paying the pre-proposal.
Oh, yes. So we pay for people at the pre-proposal stage for focus if we don't pay them if they're going to be funded at $500 a day, because none of us get paid unless we get funded. And then, so the video that we showed, this is to kind of give you an idea of what we do. So we like for people to tell their stories. This was one in which we were kind of more having a person kind of talk about how you might tell a story. But the videos that we have oftentimes are very personal. That is one thing that for ethical reasons we'll never pay a patient to tell their story, because in our community there are a lot of people who might regret after the fact having told their story if they were being compensated for that. So that's the one thing that whether there's a study going on, whether we have funding or not funding, we won't pay for people to tell their story on camera. But we now have hired a full-time person from our local news, so one of the Baltimore news stations. We've hired one of their cameramen, and one of the things we're doing now is we're developing patient archives, because we are learning in our community that people don't like to read websites, they like to listen to videos.
You were talking about your list of rules that they have to comply by or with before you'll, work with them. Do you have those written up somewhere, and would you be willing to share them, or are they shared somewhere?
So I mean, we could write them up. I mean, we don't have them officially written up because we don't want it to seem so formal. But they are basically that we have a 10-step framework, and if you don't follow the 10-step framework, which is a checklist of 10 points that you should be engaging patients from that beginning stage all the way through, we won't work with you. The second one is if you don't fund all of your stakeholders at the same advisory consulting rate, we won't work with you. We go further than what PCORI requires. If you won't engage patients before the letter of intent, we won't work with you. We can't save the day after you find out and you have 6 weeks to do the proposal, we won't work with you. If you don't want to write us into doing the work, I need to see your budget and I need to see that you've budgeted appropriately. And when they ask us what it costs to do engagement on a typical PCORI proposal, we tell them it's between $100,000 and $125,000 a year. And if you're not willing to pay for that, then you need to show me how you're going to be able to do that, because we can't do that for less than that amount of money. But a lot of that money that we get goes back to, because we take charge of paying our stakeholders, because most researchers, business offices don't know how to set up purchase orders to pay consultants. And even if they do, they don't want to do it for somebody who's getting a couple $1,000s a year. And so we tell them we need to maintain that, because we know how to get those POs. We know how to explain to a Gail Graham how to fill out an invoice, and we know that you won't take the time to do that. And that's part of engagement. And then the other thing that we do is we send people like our business office manager over to these partnering sites and show them how to calculate, 10% effort of your church secretary on a grant, because we don't want to do your budget for you. We want you to be able to go after funding without us. And what we hope is that you'll go after funding without us. And so if they don't buy into all those principles, that you're not just funding your project, you're funding this infrastructure.
Okay. Well, we were talking earlier about building a toolkit that everybody could share. I for one would really appreciate if that was in there. Yes. Any boilerplate like that, you don't follow it specifically, yes. But yes. It gives you an idea.
So what we did in our the first thing we did on our website, and it's really hard to find, so I'd have to send the links, but we have up there things like, how do you get a DUNS number? Right, but why should you have to forget? So we tell you, how do you get a DUNS number? How do you write an NIH-style biosketch? How do you write a PCORI-style biosketch if you're a patient? And those are up there publicly available, and we're trying to get our training manual done, and when that happens, we plan to share it as widely as we can. The first year was getting to know our partners, the second year was getting to know their communities, and the third year is building all those toolkits so that we are sustainable, hopefully by year 4, so we're not in our last year doing what everybody else does, which is figuring out our sustainability plan. But yeah, I'm happy to share those, and they should be available by early 2017.
Renee?
Something that both of you inferred or kind of talked about a little bit, but I kind of wanted to hear a little bit more, and that we've done, is helping the community members actually go after their own funding for programmatic grants. We are so well equipped to write grants and to teach people how to kind of go after that funding. Can you talk a little bit about ways that you've used that as something that shows that real collaboration and helping sport?
So we have a summer institute, and actually Shanini alluded to that yesterday. So when she was a postdoctoral fellow with one of our faculty, she helped to develop this. And so we invite the community to come to those types of trainings. We also have a mini-med program, which, there's a lot of things on our campus. And that wasn't our infrastructure, that was a different grant that supported that training institute. The mini-med program is funded by the School of Medicine's internal funding, so we know. So a lot of it is kind of sending people to things on our campus. And then because of a recent argument, a heated argument that I had with one of our long-term partners recently, one of the things we're now doing is bringing our partners in to sit in on when we're talking with our researchers, so they can see what we're saying and they can see what we're telling them is needed for that. And then in addition to that, we share our templates. So we not only share the templates for a biosketch, but we show this is what a letter of support should look like. These are the types of instructions you need to give to the person so they know what they're supposed to write in that paragraph, because nobody knows what to write in that paragraph, right? As I said, we have some things up online. So online we have how to do a budget, but some of that gets more granular. And so, as I said, our business manager is going over and meeting with the finance person at one of the local hospitals to explain that to them, because they have accountants there, but they've never seen an NIH budget form before. And what we're hoping to do over time is, after we've done that once or twice, then we'll film that too, so that our partners can go back and listen to it over and over again. But what we're finding is that much of what our partners want to, because our partners aren't people, our partners are institutions. They really want to know about all the bureaucracy of NIH, AHRQ, and PCORI, no offense to the PCORI people in the room. And we want them to be able to do that so that they could put their own budgets together, they could put their own biosketches together.
So I just want to pick up on that so that Makeda flags it too, is that there's a difference between Research 101 and then research institutions and funding sources. And we have Bureaucracy 101, yeah. So I think that's an important component too, that, yeah, or 911, depending on how, yeah. Anyway, I just thought that was an important point, that it was a different flavor. Brad.
I just think that's a really essential point when you're working in the community, especially when you're looking at it with an equity lens. Oh, I'm sorry. I think that's a really important point when you're working in the community, especially when you're looking at how to approach the community with an equity lens in order to build capacity and to work with these organizations or institutions. Is that you might be in an institution that can process a $5.5 million grant, and you're willing to subcontract with these community-based organizations, but they don't have the capacity to bill and invoice and keep time in the way that is federally required. And so, so it sounds like you have some amazing tools and resources, but you'll be meeting community-based organizations out there that have a budget under $100 million or $100,000, and they can't even imagine the size of the grants that we're giving them as subcontractors.
That's an important point. What other questions are there before we turn around? Makeda.
I want to clarify the point that you brought up. Understanding, you said Research 101 kind of versus understanding research.
How funding, yeah. Yeah, there's the institution themselves, how funding is allotted, how the business process or the bureaucracy process works in the funding phase. And I think a lot of times we talk about, okay, you have an award or you're developing a research topic, but we don't think about who are you going to for funding, how does that process work, how do they set their priorities, how do we deal with all of the finer details for that grants administration piece.
So that relates to the toolkit then that Daniel was referring to. So you made this comment around getting to know partners, get to know community, develop toolkits that will speak to how to navigate all those things specific to the grants.
I think there's probably a partner perspective, like who are you calling your partner? So as Daniel said, it's an organization, it's not a person. And that organization ends up being the connector, if you will, to specific members maybe within that community. And so their informational needs, and I'm paraphrasing, he can correct anything that I'm saying wrong, but their needs and information needs will be different than an individual. And so thinking about that, and I don't know what you would add.
So this may sound insensitive, and I don't mean it to sound insensitive, but it's my current belief, which may evolve, that no toolkit will ever allow an institution that hasn't done this with our leaning over their shoulder to do it the first time on their own. And I don't mean to say that institutions that aren't academic institutions are stupid or in any way, but no matter how much you explain how to do an NIH budget, the NIH didn't put up on their website something to confuse the community. They thought they were being clear. So we think we're being clearer, and we probably are, but we're still not clear. And so what I'm learning is no matter what we do, we can point you to a video, we can point you to a toolkit, but the first time you do it, you still want me or my business manager or my postdoc or somebody to sit down and do it with you and then say, this is the toolkit, make notes on it. And so that's what I'm saying. Like, I don't think we're going to have that magic toolkit that if you're not doing the type of research you think we can create. I think the first time you need to be walked through that.
The importance of mentoring.
Right.
Yeah.
But not just the science, it's the business, it's the everything. It's the how do you read an RFA? How do you know what are the 16 forms that, 2 days before you suddenly realized you were supposed to fill out? Right? And I mean, as junior faculty, we all went through that, and then to remember, oh my gosh, I didn't realize there were 16 forms. I thought there was specific aims in the science. I didn't realize there were 16 other forms. And so helping them to understand how to read an RFA and know what's required.
Janice?
Yeah, I've engaged various communities in the Islamic community that I would like to see come forward. The refugee community is one, and their friends, and I've been working with them and encouraging them to apply for a pipeline to proposal Eugene, Washington for years. And I know Children's has reached out to them on a couple occasions, and a top researcher, and he didn't really feel he had time. So I said, you know, you can create your own questions. So I threw like a whole bunch of things out of my new, they've been doing their own surveys, their own work, and being funded by public health and other entities. But he's looking at it, I don't have enough people. And I said, well, you can, this is capacity building grants. So I don't know how, what I was going to say is his question was, when I saw him again recently at the UW, he said, we need a reliable research partner. And it just shut me up, because I realized I don't know if I can really go to group health or UW. Who should I connect him with? You know, I haven't asked, but maybe it's, you know, the community CHE, I don't know. So I think this is one of the primary issues, because they're so busy. So, and the whole thing is both sides want each other. They're just not sure. His whole thing was about trust. And I was just kind of quiet, and I haven't even really talked to group health about it, because I know that there is people that are interested in doing it. So, I mean, I don't know what we can advise on that. They would need that help with business proposal. They would need somebody reliable to help them with that, to budget it out and stuff, that has already done it. Any suggestions?
I think it's when I talk about, you know, I do community-based participatory research in my organization, they somehow think about coffee time, and that's all part of it too. But it also means that I'm staying up in the middle of the night, reading their grants, giving them feedback, reviewing everything. So I feel like it takes 3 times as much to work with the community and to help them write grants, successful grants for them as well. What I have found in my work is that some community-based organizations are really good. They're just not so much with the NIH type of grant, but with program grants, they're really good. You walk them a little bit and they will get it, and they'll fast, they will know how to do it. But with some other groups, it does take more hand-holding. And we do have something very similar, like Daniel said, and I just cannot imagine how else you're gonna do it if you don't do that kind of approach, is where we bring our community partners for a grant writing session. So we advertise and we say, hey folks, you guys can attend this grant writing session, and we will review the grants, and those that are scored the highest, we will give out a small pilot to collect some pilot data that can help you to write a PCORI pipeline award. And they're not just brought to work on their own, but we partner them with a postdoc, or we partner them, like early career investigators who wants to learn about how to work with the community. So we'll partner them. So, and then we're going and we're teaching them the science and also the administrative part, but they're not always doing it on their own, but they have a scientific arm who is going to help them walk through this process. And then if they get funded through the pilot project, then whoever that was the guiding person has to work together. So it's a lot of commitment for the postdoc, but postdocs are always looking forward to having more experiences, and they're already fully funded. So that's one way that we have been doing to be able to train them so that they are more comfortable about writing the grants and understanding the bureaucracy.
But I think that's, just be honest, I think it's what scares them, because they want a researcher they can rely on, and not, you know what I mean, a postdoc they can get a lot of information from, but they want to work with researchers they know are proven research science, you know.
Yeah, so once they have been successful with the pilot and they've been working with the postdoc will probably move on to something else, then I'll step in and then I'll work with those guys. Yeah.
So I think this has been a great discussion, and now it's time to go to our tables and do similar to what we did last time, is really, you know, talk amongst yourselves in terms of your respective experiences and thoughts based on what you heard today, and answer the very easy question of what are the resources needed to support authentic expansion of diversity and patient researcher partnerships. And as we did last time, try and come up with some actionable items that we can take forward. You know, I've already heard some ideas, not only the toolkits, but what do you wrap around those toolkits, the mentorship piece, for example, the capacity building. Are there different types of trainings that would be helpful for the community to advance this? You know, some of these things may be things that we can tackle with the remaining time we have with our grant, but I also want to encourage us, and I'll do this again when we get to the prioritization, there may be new PCORI engagement awards that come from this that people in the community can take forward if there's an interest or a passion. So all of this information will be shared. It is, you know, it's information meant for the community, for us all to build off of. So you'll have pictures of what has happened. You'll have a final report, et cetera. So, convene at your tables, answer this question, and then probably about right at the top of the hour, 5 minutes past, we'll come back and do a debrief, and you can volunteer someone else at your table, or the same person can go again. All right, perfect. And again, thanks to the presenters for leading the discussion. All right. We're going to come back together now. All right, there's a last push between you and lunch. So as we did, no, you know, I think that this is a huge testament to how engaged this group is, in the sense that we started at 8 o'clock. We've been in the thick of some really intense discussions and conversations with a short break, but everybody's been back on time. And you know, the fact that I have to ring a bell to quiet things down is a big sign. So in the next 10-ish minutes, we're going to do what we did last time. We're going to go table to table and have people report out on the top 2-3 things that they think is really going to change or drive this area of PCOR forward. I'm going to ask for, same as last time, that you put things on sticky notes in case Makeda isn't able to capture it, and just so we have that recording so we know that we did capture it. So you can do that now. You can do that over lunch. After this, we're going to break for lunch. As I've said a couple times, there's no formal, you know, plan during lunch. It's just an hour. There's tables set outside. You can come back in here. You can sit on the stairs if you so choose, wherever you're most comfortable. Have lunch, and then we'll reconvene again at 1:15. Just one last note before we jump into the table report outs. That 1:15 is going to be a webcast from DC. Leah Hutchinson, who's with PCORI, is going to talk about the engagement awards, which is the funding mechanism that supported this, and talk about how PCORI is really looking at some of the infrastructure and programmatic things that we heard of from the diversity group. So we'll talk about that, and then Makeda and I are going to tag team the last session, which is really setting the chart forward. So with that, who wants to go first? We have volunteers. We're going to go here and then back to Karen's table.
So we had some interesting discussion here at our table about what's important to engage diverse participation, and one of the things that we talked about was the need to be really aware of meeting locations. We need to bring the participation to the community rather than asking them to come to us, especially when we're trying to recruit diverse, potentially marginalized folks. We need to have a level playing field for that, and certainly to offer travel support so that they are not encumbered by participating. We feel like it's important to assist our community partners with grant writing from their own perspective, so they can go after their own funding, so that they really feel an ownership of their own projects, and then have some loyalty and commitment back to the whole research process, and felt like a town hall style mentorship and instruction would be helpful from funding organizations, so that their community partners can better understand how to get through the grant writing process.
Perfect. Great, thanks for that.
You want 2 things?
You can do 2 or 3.
The first thing we talked about is sort of models of compensation and sort of the variety and differences in which those could be equitable and fair across partnerships, and also being transparent about other financial issues, such as who actually funds the research. The second thing is having supplemental funding to sustain this infrastructure in between funded research projects and where you can actually get money to do that. And then we also had quite a long discussion about the PCORI patient-powered networks and actually how can we use those as a resource to expand the diversity of the patient-researcher partnership and how those models work and how effective are they. That's actually 3.
Perfect. 3 is fine. Overachievers.
Great. So our group really just, I guess, reiterated the importance of ensuring that there's funding mechanisms to provide space for that pre-engagement. And so really being able to put the dollars where the researcher is able to engage in those activities and, receive either additional training in that. And then for the patient as well to just receive additional resources to sort of onboard them into the process. And then we also just wanted to highlight that I think mentorship was really important, both for the researcher and the patient.
Perfect. All right. Janice?
We came up with something about, we appreciated Danielle's discussion. So like utilize driven, passionate researchers who will go out into the community. And then Masha here came up with time, money, and outreach are 3 resources that are needed. But that's like one sentence with commas.
Sure. I wanted to offer a couple resources that our patient partners mentioned. One is thecommunitycafe.com as a great resource to host community cafes. Parents can host community cafes, and it's sort of around this appreciative inquiry model. So you could build, it's a way to both listen to community partners as well as build community partnerships. And then for human subjects training for community members, Project Trace through the National Ethics Center.org/trace, and I wrote these down. It's a good design for promotoras, but a good lay health or community member model for training. It's role play, it's interactive, it's great. And we did that with one of our groups. And then we have a lot of needs, but most have already been discussed, but I would say how to stay connected, how to connect and then stay connected with hard to reach patients. So we kind of have a selection bias with our groups, right? The champions are the ones that are meeting with us, but what about the people we're not hearing from? So.
That's perfect. And while we're transitioning to the last table, with regards to Project Trace, that was a tool that I learned about through doing these interviews, and I actually used that training for our patient partnerships. Kim's shaking her head because she was one of the people that went through it, because we heard that IRB training or the HIPAA training is pretty overwhelming, and we had feedback that it was really helpful, and I've since passed that along to both English and Spanish-speaking communities. So it's in that report, and we will make that available in our next plan of trying to create a central place where these resources exist. So thanks for bringing that up. All right.
So
last but not least.
One of the things we talked about was finding a way to emphasize and sell to funding agencies and other institutions the importance of things like providing food or gifts or other kinds of like small compensatory items when going into communities, particularly in rural communities or in minority communities, just the importance of, if you're asking people to show up to a meeting, you better be providing food, and how that can be a barrier in some projects because of funding limitations. And then also with the idea of mentorship, particularly in rural communities or in certain minority communities, the usual suspects always show up as engaged members of the community to participate in your projects or to express their opinion, but asking them to mentor somebody else to bring others to the table, so that it's not, so you're avoiding what Daniel talked about of not just having diverse people, but having diverse respondents, so you're not having the same people show up every time.
That's perfect. Perfect. And so a reminder too, if there were topics that didn't come up or things that you think we need to capture on there, please send those little sticky notes to Makeda. It's been really interesting to see this theme of mentorship that we didn't hear necessarily in the individual interviews, but as we start to collectively think, we see that come out. So that's the advantage of bringing these group discussions together. So go have lunch. And as I said, after lunch, we're gonna bring everything together and really start to have you guys vote on what are the things that we need to move forward as a community. Lunch is in the same place. As I said, tables out front. Feel free to convene in here, wherever you're most comfortable. Thanks to everybody.